So again, welcome. Thank you, everybody. I hope you all made it here okay. I'd like to introduce our two doctors today. And the first one is Dr. Jason Springer, who is the co-director at the Vanderbilt Vasculitis Center in Nashville, Tennessee. And Dr. Springer is also Associate Professor of Medicine, Division of Rheumatology and Immunology at Vanderbilt. His clinical interests are centered on rheumatology, and he's especially interested in treatment of vasculitis. Dr. Springer's research focus has been in the field of systemic vasculitis with the goal of advancing the care of vasculitis on a local, national, and international level. And he's been involved in several large multi-center trials and the principal investigator for multiple pharmaceutical clinical trials. Dr. Lin. Dr. Lin specializes in rheumatology. He is an associate professor at the College of Medicine, Division of Rheumatology at the University of South Florida in Tampa, Florida. He has special interest in treatment and research of systemic vasculitis. He is involved with the VCRC and clinical researches, and most importantly, he was also a co-author of the ACRVF management guidelines. And so with that, Jason, I think you have a presentation for us, and I'm going to turn that over to you. And then when we're done, we can take some questions.
Great, thank you. Welcome, everybody. We have kind of a small, intimate group here. It's good to see Dr. Lin. So me and Dr. Lin actually did our vasculitis fellowship together, and so I don't get to see him too often. So it's good to see you, even if it's just virtually, and good to see everyone else as well. So we'll be focusing on the polyarteritis nodosa guideline. And here are some of the key references, which you can look up if you wanted to. The first is the actual PAN guideline. And the second is, me and Dr. Lin were on the literature review team for this. And so the second is what was produced as part of that. And as you can see, our own Dr. Lin is the lead author on that. So I just want to give you a context in terms of polyarteritis nodosa and where it fits in terms of the other forms of vasculitis. So when we think of vasculitis, we tend to break it up in terms of the predominant size blood vessels that are involved. And so some of you may have seen this figure before, but it really kind of puts it in context where polyarteritis nodosa is a medium-sized vessel vasculitis. But this way that we frame forms of vasculitis isn't perfect. So there is some overlap in terms of, polyarteritis nodosa can affect smaller size arteries too, and somewhat overlap with small vessel vasculitis. But it is primarily a medium vessel vasculitis. And so some of the common manifestations are you can have joint involvement. It can involve the nerves. It can involve the skin, and in some patients, it can just involve the skin. And can, in fact, affect the gastrointestinal tract, the kidneys, the heart, the eyes, or in males, the testicles. And so those are some of the more common things that can occur. Now, it's interesting to look at this in a historical context. So it was really in 1866 that PAN was described by Kussmaul and Meyer, and they gave the first really detailed description, including some interesting drawings that on a microscopic level, and I'll show you that here in a second. And so when they described PAN was really the dominant form of vasculitis, and every other form of vasculitis was thought to be a subtype of PAN. But over the years, there have been several events that have occurred that have broken this up into some subdiseases or other have redefined groups of patients. And so one of those is that in 1923, there was a description, so there was a description of microscopic polyangiitis. Then in 1994, the Chapel Hill Consensus Conference kind of defined microscopic polyangiitis as its own disease. And these patients have ANCA antibodies. and that was discovered in the 1980s. And so they kind of broke out, and but they were previously labeled as PAN. And then in 1967, there was a discovery of hepatitis B, and shortly thereafter, there was the association that was described between PAN and hepatitis B. And so the one cause of PAN was discovered there. And more recently, in 2014, there was the discovery of adenosine deaminase 2 deficiency. So this is a genetic cause, and typically in younger patients. And we'll talk a little bit about that later on. So what was kind of the dominant form of vasculitis is kind of broken up into many sub-diseases. And so when we talk about idiopathic, meaning that there's not a secondary cause, PAN, that it has the prevalence of that has diminished over time. So it's becoming a more rare disease, is what I'm saying. So these are some of the pictures from the early descriptions of PAN. So on the left here, this is it actually predates Kussmaul and Meyer's description by Rokitansky. And this shows some of the arteries. These are medium vessel arteries, and these are some of the arteries going to the intestines. And you can see these little aneurysms that are forming here in the arteries. And then this is from Kussmaul and Meyer, where you can see in the heart, these coronary arteries that have these dilations. So when we go through these guidelines, I think it's important to remember several things. So these guidelines are tools for physicians, and it's very important that there is some clinical judgment that goes into this. So, these aren't set in stone. And also, these are focused on primary or idiopathic PAN. So what that means is that, some PAN is caused by hepatitis B or sometimes other infections. And so it's not really geared towards those, because hepatitis B associated PAN is treated differently. You want to actually treat the hepatitis B. The other thing to remember is that these guidelines are for multi-system disease. And so, there are some patients that have skin-limited PAN. And so this is more directed towards those that have more than just skin-limited or just more than one organ system involved. Now, Dr. Chung did a good job on reviewing the process. I'll just briefly remind you the process here. So we start with a clinical question. This was a core team. And they came up with multiple clinical questions for PAN. And then the literature review team, which me and Dr. Lin were part of, we looked through the literature and found those articles that were most relevant to each clinical question. And then we rated the level of evidence from there. And then this got sent to the voting panel, and then they would vote on and develop the recommendations that we have now. And it had to be a consensus vote, and there was patient representation on there as well. And each of these has a direction, so either for or against. And as Dr. Chung pointed out, each of these have a strength to them, and either strong, meaning applicable to all or almost all patients, which in this is a very rare disease. So, we don't have huge studies. So it's hard to have these big controlled studies. And so there is actually just one strong recommendation in the PAN guideline, and we'll talk about that. Most of these are conditional, which means, as Dr. Chung had said, this warrants a shared decision-making approach. And then we'll talk about, there are some ungraded position statements, which means that there really wasn't enough literature there to make a strong statement, but the voting panel felt like they should make some recommendations, and that generally reflects the views of the voting panel, which are made of vasculitis specialists. So I'm going to ask you to kind of change your view. So you're going to be looking through this as in the eyes of the treating physician. And now this is a picture of from the NASA website. It's called the City in the Clouds. And what it is somebody's taking a picture outside their window in a plane. And what you're seeing here is actually Chicago, which is reflected in the water. So we're going to do this in some cases. I'm going to present some cases to you, and we'll go through the guidelines and how they are relevant to those cases. So the first case is a 42-year-old gentleman who presents with a 1-year history, and he's having these skin ulcers, which means skin breakdown. And you can see that here on the right. And 1 month ago, he developed a weakness in his right foot to where he couldn't raise his right foot and it was dragging. So he is presenting with 2 very common manifestations of PAN, including skin involvement and involvement of the peripheral nerves. And ideally, what we want to do is try to confirm this by biopsy. That's the best way to confirm it if we can. The skin is one area where we can biopsy, but it does pose somewhat of a challenge. Now, I've shown you some examples here of what PAN skin involvement looks like on the top here. So it tends to be a little bit deeper compared to other forms of vasculitis, and it can present as kind of this raised, kind of nodular feeling thing under the skin. Sometimes it has this livedo or net-like pattern. This is what we call livedo racemosa. As opposed to small vessel vasculitis, which can look very similar, but it tends to have more little dots and what we call palpable purpura. This is more superficial in the forms of small vessel vasculitis. So this is actually is easier to get to. You don't need as deep of a biopsy to get to this, as opposed to PAN, where the blood vessels that are involved are deeper in the tissue. And so you need to get deeper in the tissue to actually see the blood vessels that are involved. So that leads us to one of our first conditional recommendations, to get a deep punch over a superficial punch biopsy. And what that means is that the dermatologist, they use this, apparatus where they get they take a little punch out of the skin. Typically, that's not enough to get deep enough. So a lot of times what they'll do is after taking that punch, they'll take another punch and go a little deeper. And that gets us to those medium vessels. Now on the left here, this gives you an example of what we would see on the skin biopsy. So on the top here, so this is an artery, and what you see here is you see all these purple little dots, and these are cells that are inflammatory cells, and basically destroying the blood vessel. And you kind of see loss of the architecture of this artery, and you see some debris here, this kind of pinkish material, what we call fibrinoid necrosis. And then on the bottom here, this shows a artery and a vein. And what you see is all these little kind of purplish dots, which are invading this artery. And you see this border in the artery, one of the lamina is disrupted. It's basically destroyed. And then compare that to the vein, where see this big vein here, there really isn't a lot of inflammatory cells in the vein. And it's got a good laminal layer here that's not disrupted. So PAN tends, it affects the arteries and it tends to spare the veins. Now, another place that we can look for a biopsy is the nerves when there is nerve involvement, like in this patient. And so we call this peripheral neuropathy. It can present as either a motor neuropathy, meaning that you get weakness that doesn't go away, or a sensory neuropathy, meaning that you get numbness that is persistent. And it likes longer nerves. And what that means is that typically it's going to be like in the hand or foot, where the classic presentation would be like a hand drop, where you have a hard time raising your hand or there's weakness there, or a foot drop like in this patient, where you're dragging your foot, or you have a hard time lifting up your foot for stairs, things like that. Now, if we went for a nerve biopsy by itself, the yield is only 50%. So this leads us to one of the other recommendations that if you do have somebody that has suspected PAN and has peripheral neuropathy, it's recommended to get both a nerve and muscle biopsy. And this is supported by several studies. And the reason is because if we get both the nerve and muscles together, we can increase our yield of seeing the vasculitis as high as 80%. And it really doesn't add a lot more risk. You're already getting a biopsy anyway. You're already in there. So you just get a little bit of muscle, and then it can help you out. Of course, you want to target the area that's involved. So if it is a neuropathy in the legs, typically you're going to target one of the nerves there, or if it's in the upper extremities, you'll target one of the nerves there. So our next case is a 25-year-old gentleman who has had several months of fatigue, weight loss, high blood pressure, and abdominal pains. And he gets a CT, or what's called a CAT scan, which angiogram. And this shows small aneurysms in his mesenteric and renal arteries. So this is another presentation that, he doesn't have skin or nerve involvement. Unfortunately, he doesn't have easy tissues to biopsy. It's more the arteries that are very deep inside. And so this, on the left here, this shows what the kidney artery should look like. So it is a, so this is a catheter that they're using a catheter to do this, which you can see here. And then this beam-shaped structure is the kidneys, and you see kind of this tree-looking structure. And these are all the arteries that they're lighting up. And you can see they're very smooth and they branch very nicely. And compare that to the right, where this is a patient with PAN. And you see in kind of these segmental branches, you see these little aneurysms, kind of like these little outpouchings that occur. And you see that on this picture on the right as well. This is an example of what you can see in the arteries going to the intestines, or the mesenteric arteries. And on the left, again, this is a catheter angiogram, and they're shooting dye into these arteries to visualize them. And you can see the arteries look very nice. They branch out. There's no aneurysms that you can see. And compare that to the right, where this is a patient with PAN, that you can see those, if you look closely, you can see, well, here's a big aneurysm, and you can see other little outpouchings as well. And then there are areas of stenosis where, there's, smaller area, and then areas that are dilated as well. So this, this is very typical for PAN. So the problem is these areas are very difficult to biopsy, as opposed to the skin and the nerve. There's a lot more risk in biopsying these arteries. So what do we do here? The guidelines do recommend that for those patients with a suspected PAN, you can use abdominal vascular imaging to help you diagnose and also determine the extent of the disease. So, if you see those classical features of PAN on the arteries, then that can really help you in terms of diagnosing the disease. But not only that, it helps you in terms of determining the severity of the disease, and can help you in terms of prognosis as well. And if you do see areas of aneurysms, it's important that you they're there, so that you can reassess them down the road. So you get repeat imaging down the road to see how these aneurysms are behaving. Now, the caveat to this is, remember, this is not applicable to PAN that's limited to the skin. So these guidelines are primarily for multi-system disease. Another recommendation is that those with a history of PAN and abdominal involvement who become clinically asymptomatic, meaning they go and look like they're in remission, that you do need to do follow-up abdominal vascular imaging. Again, you want to follow those aneurysms, make sure there's no new areas that form with aneurysms. So our next case is PQ, who's diagnosed with PAN, and he's tested for hepatitis B and C, which are negative. And also you look at other mimics for PAN, which are ruled out. And he's ready to start treatment. So how do we make the decision on treatment? Well, when we look at treatment, there are several considerations that we take in mind. So the first is that we want to make sure that this is primary. And what that means is that it's not due to another cause. So in this case, hepatitis B was tested for and was negative, and other infections like hepatitis C, also other mimics. So, you want to make sure that this isn't sometimes small vessel vasculitis, like ANCA-associated vasculitis, can look very similar to PAN. And so you want to make sure this isn't one of those other forms of vasculitis, or some other autoimmune diseases can cause a medium vessel vasculitis as well, like sarcoidosis. And then you want to define the severity. And in the guideline, they break it up into severe and non-severe disease. And what severe means is that there are organ or life-threatening manifestations. So for instance, peripheral neuropathy can lead to damage that can be permanent. So that would be severe. Or GI involvement would be considered severe as well. Now, when we think about treatment, we also tend to think about this in phases. And Dr. Chung had mentioned this, went into this a little bit. We tend to think of this in terms of induction phase, where the disease is active. We want to get control of the inflammation, prevent organ damage, and prevent infections. And then at some point, we want to get to a remission state. And this is basically that there's no evidence of active disease. Now, that doesn't mean that there isn't damage. There may be damage from when the disease was active, but we don't want to see anything that looks like it's, that the PAN is active. And then we're in kind of a maintenance phase where the goals there are to prevent relapses, to help minimize the steroids, prevent side effects from the medications, prevent infections, and improve quality of life. Unfortunately, if there's relapses, then we kind of go back to that induction phase. So the guidelines, they recommend that for severe disease, conditionally, this is a conditional recommendation that patients get treated with high dose steroids, either oral or IV steroids. And in addition to another agent. Now, the cyclophosphamide is one agent that is one medication that we have a little bit more data on, and we know works pretty well in this disease. And so they specifically mentioned that. But again, there is some clinical judgment that goes into this as well. So the GQ is treated with oral cyclophosphamide along with high dose glucocorticoids over a period, or steroids over a period of 6 months. And at a 6-month follow-up, he's feeling well. His blood pressure is under good control. His weight has been stable, and you get repeat vascular imaging, and all these aneurysms that we saw, they look stable. There's no new aneurysms, and he's felt to be in remission. And so what do we do at this point? Well, the guideline would recommend that if once patients are in remission, if they are on cyclophosphamide, it is by 3 to 6 months, typically, you do want to change them to a less aggressive agent. So typically we change them to, some examples would be like methotrexate or azathioprine or mycophenolate, things like that. And if you do have somebody with PAN that is in remission for 18 months, it's reasonable to consider trying to get them off of therapy, because in the literature, PAN does tend to relapse less commonly compared to some of the other forms of vasculitis, like ANCA-associated vasculitis. So this is something that's different in PAN compared to the ANCA-associated vasculitis guidelines like GPA and NPA. Also, it's recommended that the steroid taper be guided by the patient clinical condition, values, and preferences. So really taking into mind the patient and their individual needs. And if they're not in remission, then considering a different medication, a different immunosuppressive medication. So the next case is a 56-year-old female who is diagnosed with PAN 7 months ago, and she presents with nerve involvement and skin involvement, and now she's felt to be in remission. So she had nerve involvement. How should you monitor that, and how would you manage that long term? So one of the recommendations support that if there is a history of nerve involvement due to PAN, that they be monitored with a neurologic exam and not getting repeat EMGs or nerve conduction tests. And what these are those needle tests that test the conduction of nerves. And so they're invasive. And so it's not felt that you really need to repeat those for monitoring. They're really best for like diagnostic purposes. But the caveat to this is if you have a new manifestation, like for instance, if you have a new area of numbness or weakness, and you wanted to make sure it's PAN and not something else, like it's not from the spine or something, then it makes sense to get an EMG or nerve conduction study. One of the other recommendations is that those patients that have nerve or muscle involvement, conditionally recommending physical therapy. And the reasoning behind this recommendation is that physical therapy is a benign intervention, and there are definitely people that get a lot of benefit from physical therapy, but it should be at the discretion of the physician. So the next case is a 50-year-old female who is presenting with well-controlled hypertension, who comes for evaluation of rash, joint pains, fever, and unintentional weight loss. A deep skin biopsy confirms PAN, and hepatitis B and abdominal vascular imaging is normal. So how should she be treated? Well, this is a different scenario compared to the other gentleman. And so this patient would be considered to have non-severe disease. So we don't especially have to be as aggressive here. So the recommendations suggest that if you have non-severe disease, that you do induction therapy with the steroids in addition to something less aggressive. And examples here include methotrexate and azathioprine. Now, the next case is a young lady who is has a history of inflammatory arthritis and developed unexplained abdominal pains, fevers, weight loss over the last month. And so she had a CT angiogram to look at the blood vessels in the abdomen, and you see those microaneurysms that we saw that I showed you earlier, something similar to that in the arteries going to the intestines. And she has this unexplained stroke that happened 1 year ago. So this is a case that is this is a very common, this is a common presentation for a disease that was recently described called Adenosine Dyaminase 2 deficiency. And so this was described in 2014. And it's a genetic cause of the disease. And so she's tested for these genetic mutations. And the gene that's involved is the ADA2 gene. And so she's found to have these mutations. And then also you can check the enzyme that's involved. So it's called the ADA2 enzyme. And typically these levels are low. So this adenosine deaminase 2 deficiency, or DADA2 for short, we'll just call it DADA2. It presents just like PAN, so it can look identical to it. So just like we saw in the other pictures, so you see these aneurysms that are forming in the arteries going to the intestines. And if you get a biopsy, again, you see a medium vessel vasculitis, the same as you would see in regular PAN, with these inflammatory cells and destruction of the artery. And then the skin involvement looks exactly the same as well. Now, there are some clues to this disease. So it tends to be in younger patients. This disease is something that we try to consider in young patients that were diagnosed with PAN. Also, strokes are a feature of it. So we consider it in PAN patients that have a history of strokes. And then there are some other things that are a little bit different from regular PAN. So sometimes there's low blood counts, or there is a predilection for infections, things like that. So there was a recommendation that was included in these guidelines for this population with DADA2. And this is actually the only strong recommendation in the guideline for PAN. And it recommends using what we call TNF alpha inhibitors. And TNF alpha, it's basically this inflammatory cytokine in the blood that we try to block with these medications. And so the ones that have been looked at here is infliximab, etanercept, and adalimumab. And so, this is based on data that came out from the NIH, and they had patients with DADA2 that were that they started on these TNF inhibitors. And essentially, these patients that used to have strokes all of a sudden stopped having strokes, and none of them had any strokes after starting the TNF inhibitors. And it wasn't a large study per se, but it was fairly dramatic results from this medication. So right now, this has kind of become the gold standard for treating these patients. And so that's why this is a strong recommendation here. So, and also, I think it's important to consider data too in the setting of patients with PAN that are younger and have strokes as part of their disease. So I will stop there and let's see. I'll let Dr. Lin, do you want to kind of guide the discussion?
Yeah, sure. So thank you, Dr. Springer. That was a great overview of the clinical practice guideline for PAN. And I think we have a good amount of time to do some question and answer. So we're going to try our best to go through all of them. So the first question is, do these guidelines cover systemic PAN and does it include cutaneous PAN? I think this question was discussed by Dr. Springer. So this guideline is mainly for systemic PAN. So why don't we go to the second question? The second question is, can you explain why the guidelines recommend a double punch skin biopsy and sampling both the nerve and the muscle tissue together? So I think this was also discussed. Do you have anything to add, Dr. Springer?
Yeah, so it's mainly about we want to increase our yield for the biopsy, and including that muscle tissue can be very high yield with not really adding on risks. So that's what led that recommendation.
Great. So the next question is about a very popular medication for our systemic vasculitis. So the question is, do the guidelines cover the question about the use of rituximab for patients with PAN?
Yeah, so the literature in PAN, as opposed to the forms of ANCA-associated vasculitis, we don't have great literature behind the use of rituximab. And so it was recommended using cyclophosphamide, which we have a lot better literature on compared to rituximab. Now, that being said, there are some special things we need to consider regarding rituximab in this population. So you don't want to use rituximab in a patient with hepatitis B. And as we talked about, hepatitis B is a major cause of PAN. And so, it would not be an appropriate therapy in somebody that the hepatitis B is driving the PAN, because it can make it worse. Not to say that it doesn't work per se. I mean, in certain situations, we may use rituximab. We just don't have as much data in this space as we do compared to other forms of vasculitis.
All right, yeah, so we're gonna stay tuned. I think there's gonna be more data coming up. So on to the next question. So what led the panel to recommend disease-modifying anti-rheumatic drug, or we call DMARDs, therapy instead of using glucocorticoids alone? And this is in the setting of a systemic PAN, I assume.
Yeah, so I think it's important to kind of define what is these DMARD therapies, and these are therapies that they're disease-modifying therapies that help us limit the amount of steroids. So examples of that would be like cyclophosphamide or methotrexate or azathioprine or mycophenolate. So the reason we add them to the glucocorticoids or the steroids is that in some of the earlier studies, when they used just steroids alone, there was a high relapse rate initially, where they would treat them with the steroids alone, but then they'd have to put on these other agents because a lot of them were relapsing. And so that's part of the logic behind not just doing the steroids, but also doing another agent, so that you can help both get off the steroids, but also help prevent relapses. Yeah,
so I agree. And also to keep in mind that, some of our patients also cannot tolerate steroid, or they have pretty bad side effects. So these are all the factors that has been, considered by the panel. So next question, did the guidelines consider any information regarding IVIG or immunoglobulin infusion? How about vagus nerve stimulation and or plasma exchange as a treatment for PAN?
Yeah, so in regards to All of those are, there's very limited data on, so I don't think we can draw firm conclusions on that. Yeah, it's just because of a lack of data. I don't know, do you have anything to add to that, Dr. Lin?
Yeah, I think we did a little bit of discuss a little bit of the plasma exchange on the discussion. Definitely IVIG, and these are considered probably fourth line, of treatment options. I rarely have to go through IVIG. It's something that's rarely used. Vagus nerve stimulation has been gaining some attention for a patient with variety of different systemic autoimmune problem. And there's some theory about, regulating, your autoimmune system, inflammation. But like what Dr. Springer said, there's just not enough studies, or good clinical trials to look into this intervention. So, but a very good question. And I think we have to stay tuned for more information. Okay, so let's go to the next question. So I understand one challenge in the guideline was not always having the robust studies like randomized clinical trial. Did you encounter this issue with the PAN guidelines?
Oh, yeah, definitely. So there are very few randomized controlled trials in PAN. And what's difficult with PAN is we went over a little bit of the history of it. And so remember, this over time, the definition of PAN's changed. And so, there have been these subgroups that have broken out. And so if you look at some of the earlier studies, which are some of the, randomized studies, they actually include patients that have hepatitis B, or they may include patients that have microscopic polyangiitis. And so that makes it a little bit more difficult as opposed to, an ANCA-associated vasculitis, where it's pretty clean that the studies just include ANCA-associated vasculitis. Because some of these are earlier studies, it does have some of those other groups in it. So ideally in the future, it'd be great to have a just idiopathic PAN in studies. But I don't know what your experience is, Dr. Lin, but it seems like it's idiopathic PAN is becoming more and more rare, I feel like, with maybe better treatment of hepatitis B and maybe finding the causes. And yeah.
Yeah, I totally agree. Clinically, you're seeing them less and less because we're now able to classify this patient with undifferentiated or unclassified vascular or suspected PAN. We're able to classify them better into a more specific kind of vasculitis. Just like what you mentioned, the data too, So I think these probably going to eventually get less frequent, but I'm sure there's still a lot of, primary PAN out there. And just to drive home the message also, what Dr. Chung said, this clinical practice guideline is the beginning, okay, of our endeavor. We're trying to find, more clinical data that are good evidence-based. And this clinical practice guideline is to hope to stimulate more, trials or studies that will be done in the coming years. Okay, so let's go to the next question. So this is more clinical question. What is the recommendation if patient failed CELSEP and is having a liver problem, like high liver function test, or they couldn't have any, or they have any side effects with Immunon or methotrexate leading to liver function abnormalities? Is rituximab an option?
Yeah, I think, definitely you have to take in mind the other things that are going on, like medications that can affect the liver function test, like methotrexate, you'd want to avoid in somebody that has liver issues, But I think rituximab is a reasonable option if, if you still need something to control the disease, but you've exhausted other means. I think it is an option. Just because we don't have the data doesn't mean it doesn't work. So yeah, I think we can potentially use it, but again, you do need to make sure that there is no hepatitis B.
Yeah. So another point is, as we starting to know more and more about the immunopathogenesis of PAN, now with more specifics, basic science, I think, we'll be able to come up with more targeted therapy, in the future. So next question. So I can add the same. Are there any supported treatment routes or treatment options that do not include steroids?
Oh, yeah, that's a good question. And, I think in vasculitis in general, we're entering an era where we are trying to limit or completely eliminate the glucocorticoids, because we do know, or the steroids. We do know it's kind of a double-edged sword. We know that they work quickly and they work very effectively, but they have a lot of possible side effects. Now, I think, unfortunately, there's probably more progress being made in ANCA-associated vasculitis, probably because it's a little bit more common in terms of finding agents that either replace steroids, or some studies that showing, you could put on a medication and reduce steroids a lot quicker. Like in Giant's arteritis, we have a new medication where you might be able to get off of it quicker. But unfortunately, we just don't have that yet in PAN. But I think we're in that era where we're trying to reduce the amount of glucocorticoids.
Yeah, I think we should be doing these trials, right, Jason, with the steroid sparing regimen, just like what we have for GPA. But again, once we learn more about specific immunology, what the pathology, I think we're going to have more targeted therapy addressing the PAN. So the next question is, what is the average time on treatment with drugs before you see remission?
Oh, yeah. PAN tends to relapse less than some of the other forms of vasculitis, so I think that there are a significant number of patients that'll have a relapse and go into remission and then do very well. And so I think it is variable. I can't say that there's an average per se, but I think by 18 months, like I said, if you've been in remission for 18 months, I think it's reasonable to consider coming off of therapy. But that being said, you do need to monitor the disease.
Well, I'm just going to piggyback on this question, Jason. In clinics, and I'm sure all of the rheumatologists or vascular specialists usually have, a lot of patients asking this common question. So the question is, how long should I stay on the immunosuppression or the prednisone? Assuming they're in remission. So they ask this all the time, like how long? So do you want to kind of talk a little about it? Through the clinical practice guideline?
Yeah, well, the guideline recommend, the discretion of, the physician and in talking with the patient and stuff, and basically individualizing it. But as far as so I can say in my practice, like I said, we put on another agent, another DMARD agent in addition to the steroids. And I try to get down to either low dose or off in the 3 to 6 month range, and adjusting it based on the patient. And what's your practice, Dr. Lim?
Yeah, so definitely, I agree. It's case to case, patient's preference. But if you're looking at the different rheumatologic problem, like example GPA or rheumatoid arthritis, psoriatic arthritis, the direction most research are showing is that you have to try to stay for as long as patient can tolerate, and just like in GPA, for example, like the main recent trials, they've been doing 5 years of rituximab. So looks like the longer you stay, the better your chance of a relapse-free survival. So I think we probably need more studies, addressing this question in PAN. So far, I think, when we were trained, we were trained to say, well, 18 months, 2 years, you can try to come off. But I think, this kind of, mindset might be changing, right?
Yeah. And I think going off of what you said too, there's the prior manifestations matter too. So if if I have somebody that had severe disease in the past, I may be less likely to try to come off of therapy as opposed to somebody that had non-severe disease, So for instance, if you've had like mesenteric involvement, that's, those are patients where I would want to do longer therapy in terms of, in terms of that remission therapy before coming off, attempting to coming off of immunosuppressives.
Yeah, I agree. Okay, and okay, let's go on to the next question. So could you share 2 to 3 of the most important takeaways from the recommendation for PAN for us, the average patient? What are the key things that we should understand about the PAN guidelines?
Yeah, in terms of, I think the data too is important to think about when, if you're a young patient with PAN or you've had a history of strokes, I would maybe consider that. Or if there's a family history of PAN, then, because the reason is because data 2 is treated pretty differently compared to regular PAN. And so it is important to recognize that. So, I think that is one important thing to come away from this. The other thing is probably in terms of how to recognize it, in terms of the biopsies, getting the punch within a punch, getting deeper biopsies is important. The fact that we do need to use steroids with another agent, typically for induction therapy, I'd say those are the some of the more important points. Do you have anything to add to that, Dr. Lin?
Yeah, so I think for average patient, I think what these tell us that right now we do have, this is the first clinical practice guideline that has ever been formed for PAN, and this does show and support that what the vasculitis specialist or your rheumatologist doing is consistent with what the guideline is showing. So I think this gives us more confidence that we're giving optimal treatment to our patients. On the other hand, this also kind of humbles us that we still have to do a lot of work. A lot of research needs to be done so that we can try and give better quality of life to our patients, and try to get them off the steroids, trying to minimize the drug-related toxicities. So I think this is a good start, and I think that's probably the most important takeaways that I get from this.
Yeah, and to give you an idea on the how these studies work. So to do these large studies in not just PAN but other forms of vasculitis, we have to include multiple centers. So it's like my center and Dr. Lin's and several others. So there's a lot of different vasculitis centers across North America, and to do these large good studies, you really have to have participation from many centers. So since they're rare diseases.
Correct. I agree. So, right, we have 5 minutes left. So we have 2 more questions, and then I think we're good. So the next question is, do the guideline discuss the type of imaging like MRI, CT scan, ultrasound for the use for long-term monitoring of PAN damaged arteries, specifically the abdominal arteries?
Oh yeah. So there isn't a recommendation that specifically says which one to use, but I'll say that there are certain modalities that aren't very great in this situation. So MRA is okay. It doesn't get as much detail in the in this smaller caliber vessels. Ultrasound also is maybe difficult to really get good visualization, and so I use CTA a lot. Sometimes just because the CTA gives you pretty good detail of those blood vessels, and because some of them are very small. And the other thing is sometimes we use conventional angiograms. So that's where they use a catheter and go up. Many of those pictures that I showed you were conventional angiogram, and where they put the dye in particular vessels. And that's a very detailed approach. It's invasive though, so it's better used to help make the diagnosis. Whereas over time, I would tend to do like a CTA, which is non-invasive, to kind of follow up with things.
And then how about the long-term monitoring? How frequent would you do it, and for how long?
Oh yeah, that's a good question. You know, so it's good to have baseline imaging definitely on everybody, even if you even if they don't have any symptoms of you know, abdominal involvement. It's good to know if it's there or not. As far as like follow-up, so you know, if there is no evidence of you know, involvement of the abdominal vessels, then you don't especially have to do follow-up imaging unless they have new symptoms. Whereas if you do have somebody that has aneurysms in those mesenteric arteries or the renal arteries, you know, again, the guidelines don't say a specific time point, but I would typically, you know, at the beginning, I would do it more frequently, maybe in 3 to 6 months after starting therapy, and then maybe 6 months after that, and then a year after that. But it is, for me, it's very much guided by how the patient presented and stuff. And so there may be some patients where I really want to get imaging sooner, you know. Now we do have to keep in mind that CTs do have a little bit of radiation exposure, so we don't want to do them too often, but we do need to follow up on these aneurysms when they're there.
Yeah. So yeah, again, the key here is the severity and the stability of those arteries or the defects. All right, so going to the last question, Dr. Springer, do you anticipate what recommendation may change or be explored for future guideline for PAN updates? Are there any areas in these updates that really need further exploring?
Oh yeah, there's a lot of need in PAN, definitely. So I think we'll see a lot more research in the future. I think you know, more like in other forms of vasculitis, we need more targeted therapies. So right now we're still using kind of non-specific therapies like cyclophosphamide or methotrexate, and we need something that's geared towards specifically the pathogenesis of PAN. I mean, I guess we've come, you know, so in those patients that have a history of hepatitis B, you know, we know the cause and that specific therapy that you treat those patients with. But for idiopathic PAN, we need to know more about the pathogenesis so we can come up with better directed therapies.